Today my presentation is going to be on the impact of alcohol and alcohol use disorder in patients with opioid use disorder. I have no actual or potential conflict of interest in relation to this presentation. All right, so just a little bit of a background. So opioid use disorder is frequently associated with polysubstance use and alcohol use disorders. Together, this is associated with significant morbidity and mortality. Currently, there is little guidance outlining effective management strategies for these patients with dual diagnosis. Currently, most alcohol research excludes patients with opioid use disorder and vice versa. Approximately 1/3 of patients who receive medication-assisted treatment, such as methadone or buprenorphine naloxone, also misuse alcohol. And often, alcohol misuse is undiagnosed and untreated. So what is like the neurobiological interrelationship? So both alcohol and opioids induce dopamine release in the ventral tegmental area and nucleus accumbens. The psychotropic effect of alcohol is in part mediated via the opioid endorphin system. Alcohol stimulates release of these neurotransmitters, so beta endorphins, enkephalins, and dynorphins. Opioids stimulate alcohol intake via the paraventricular nucleus. Opioid receptor blockade decreases alcohol intake, and I'm going to show you this in a picture in just a second. Both alcohol and opioids are downers. Together, they have a strong sedative effect and can cause respiratory depression. Studies have addressed the possibility and the role of mu opioid receptor polymorphisms in mediating the genetic risk for alcohol or other substance use. So here is the image I was referring to. So it shows the neurobiology of alcohol addiction and the role of the opioid receptor. So as you can see, it's basically the reward pathway that's involved. So just over here really quickly, so say if a patient drinks alcohol. So when the patient drinks alcohol, that stimulates the mu opioid receptors. Activation of the mu opioid receptors prevents the release of GABA, and GABA is our inhibitory neurotransmitter. So without an inhibition of GABA, that actually prevents the removal of dopamine, and dopamine actually increases in the nucleus accumbens. So this is actually one of the pathways of kind of understanding of how the opioid receptor plays a role with alcohol addiction. And I think when they're referring to inhibition of the release of GABA, it's specific to this pathway. So in terms of the prevalence of alcohol use disorders in patients with opioid use disorders, so the estimates actually vary. Approximately 1/3 of patients in methadone treatment are assumed to have alcohol problems. Meta-analyses of US clinical trials found alcohol use disorder in 38 and 45% of patients seeking treatment for opioid use disorder. So now I'm going to talk about some studies that have shown, in terms of the prevalence outside the United States. So data from the British National Treatment Outcome Research Study, also known as BNTORS, conducted a large prospective study of drug users, and it showed that at the time of enrollment in a community methadone clinic, just over 1/3 of clients were drinking alcohol above the recommended limits. Another cross-sectional study of current or former heroin users attending primary care for methadone maintenance treatment, and this was done in Ireland. This revealed the prevalence of problem alcohol use to be approximately 35%. So why do we care about this? What are the adverse clinical outcomes? So a combination of alcohol use and opioid use leads to poor compliance and poor adherence to treatment. There is an increased risk of fatal overdose. There's an increased risk of relapse to opioids or other substances, drug-to-drug interactions, and especially alcohol's interaction with methadone. Now, hepatitis C is common among patients with opioid use disorder. Prevalence estimates currently range from 64 to about 100% in many cohorts. And chronic alcohol intake is a risk factor for progression to cirrhosis, especially in these patients with hepatitis C. In addition, drinking alcohol and using opiates at the same time can exacerbate psychiatric comorbidities such as anxiety, depression, suicidality, can lead to a reduction in the quality of life, reduction in social functioning as well. And also, the concurrent use of alcohol and opioids may interfere with treatment for chronic pain. Alcohol and opioids activate many of the same neural circuits and can disrupt the pain signaling pathway in the brain. So let's talk here about overdose and mortality. So alcohol use disorders are associated with an increased risk of fatal overdose and opioid dependence, as I had mentioned earlier. There was a cross-sectional study which examined the number and causes of death among participants of a methadone maintenance treatment program, and this was done in Australia. And this demonstrated drug-related death to account for the highest proportion of mortality, so which was approximately 44%, with alcohol use being cited as the third most common substance of use after benzos and other opioids. So what does SAMHSA say? So SAMHSA, also known as the Substance Abuse and Mental Health Services Administration, in their guidelines say that pharmacotherapy with buprenorphine for opioid addiction will not necessarily have a beneficial effect on a patient's use of other drugs. It is important that these patients be referred to treatment for the alcohol indication or alcohol addiction, and to other types of drugs when indicated. And we must exercise care when we are prescribing patients on buprenorphine, and we must counsel them about the potential interaction, especially fatal interactions with concurrent alcohol use. So what is the role of MAT on alcohol consumption? The interaction of opioid dependence, maintenance therapy, and alcohol consumption is complex. The studies are mixed. There is no clear pattern concerning the effects of medication-assisted treatment on alcohol consumption. There was a study that was conducted by Capita and others that showed short-term methadone treatment was associated with a reduction in alcohol levels, while long-term therapy resulted in increase in consumption. There was another 12-month longitudinal study of individuals with both heroin addiction and alcohol dependence, which demonstrated both methadone and buprenorphine to be associated with a reduction in alcohol use, with buprenorphine being more efficacious. Recent meta-analyses involving 15 studies showed no clear pattern. There were 3 studies which indicated increase in alcohol consumption during treatment with MAT, 3 studies indicating a decrease in alcohol consumption, and 9 studies reporting no change. So as we can see, right now, the studies are quite mixed. Screening. So it's important for us to screen our patients for concurrent alcohol use, especially our patients on MAT. So we have self-report measures using validated tools. And some of these include the National Institute on Alcohol Abuse and Alcoholism Single Question Screen, the Audit Questionnaire, Alcohol Use Disorders Identification Test, Michigan Alcoholism Screening Test, and the CAGE Questionnaire. We often should use self-report measures in combination with alcohol biomarkers. So here I have a picture of the Audit C Questionnaire. So the Audit C is actually a brief alcohol screening instrument. We can identify patients with a hazardous drinking and active alcohol use disorders And the Audit C is actually a modified version, usually has about 3 questions scored on a scale of 0 to 12. Usually for men, if there is a score above 4 points, that's considered to be a positive. And women, if it's more than 3, that's considered a positive. And if the Audit C is positive, then I would conduct a full audit screen. The higher the score, the more likely that the patient has a drinking issue. So here's a table showing the detection of alcoholism and opioid dependence. So in terms of a clinical picture, so CNS symptoms, liver disorders, behavioral symptoms, intoxication, so blood alcohol concentration, if a patient's experiencing withdrawal symptoms like tremors, sweating, blood pressure increase, or other autonomic instability. Psychometric scales, the audit screen, like I had just mentioned, the addiction severity index or others, and psychosocial, so if the patient's not really responding much to treatment or have any indication of clinical deterioration. And as I had mentioned before, the clinical correlates of AUD in opioid-maintained patients, so increased mortality, non-compliance, non-adherence, poor health, and often higher dosages of opioid maintenance drugs, and perceived stress and a low quality of life. So how much is too much? So per the National Institute on Alcohol Abuse and Alcoholism, for men consuming more than 4 drinks in any day or more than 14 drinks per week, for women consuming more than 3 drinks in any day or more than 7 drinks per week. But of course, in our patients who have opioid use disorder and are on maintenance therapy, we don't recommend any form of alcohol. So let's talk a little bit about the role of biomarkers. So what do biomarkers help with? So they help screen for alcohol problems. They provide objective outcome measures. They screen for individuals who are unable or unwilling to accurately report drinking behavior. And as we know, this happens often in the addiction setting. They enhance patient motivation to quit or reduce drinking, identify relapse early, and a fear of detection biomarkers may actually dissuade our patients from drinking. So let's talk about these biomarkers. What are they? So biomarkers include indirect tests. So these are more of the traditional tests that we have used. And then we also have direct testing. So in indirect testing, so we have manifestations of organ damage often due to drinking. These include gamma-glutamyl-transferase, so GGT, AST, ALT, MCV. And then we also have carbohydrate deficient transferrin, which is a reflection of alcohol's effects on other metabolic processes. So usually these indirect testing are blood-based, so GGT, AST, and ALT are actually produced by the liver itself. In terms of carbohydrate deficient transferrin, the mechanisms of this is not completely understood. For direct testing, so we have ethyl glucuronide and ethyl sulfate, and we also have PETH, phosphatidylethanol. These testing show us, so basically it's most of these metabolites are when the liver undergoes, or alcohol undergoes oxidation by the liver. All right, so this table over here shows a window of assessment for various alcohol biomarkers. So as we can see towards the left side of the table, blood alcohol concentration can detect up to hours. In terms of ETS and ETG, it can detect alcohol for several days. And long term, we have our PETH, carbohydrate deficient transfers, and then GGT, AST, ALT, and MCV. Here is a summary of alcohol biomarkers by its particular use. So that was a lot. I'm hoping to summarize this really quickly so that way we can kind of keep things straight. With the CDT, it can use to screen for heavy drinking, and it can identify relapse, especially to heavy drinking. The time to return to normal with abstinence is usually 2 to 3 weeks, so definitely detected for a long period of time. ETG and ETS usually detected for 1 to 3 days. And as you can see, we can't use this to screen for heavy drinking. However, we can use this to identify relapse to heavy drinking, and we can use it to monitor abstinence. I do want to make a point that ETG and ETS can be positive even after low-level exposure to alcohol. So say, for example, a patient uses mouthwash, they can test positive for ETG and ETS. So counseling patients, especially if they've been abstinent, and because that could have, some negative impact on them, especially if it's testing for job purpose and so forth. GGT can screen for heavy drinking, and it can show, it can be positive for 2 to 4 weeks. MCV up to several months, and it can also screen for heavy drinking. PETH up to 2 to 4 weeks, and it can identify relapse to heavy drinking. AST and ALT can screen for heavy drinking, and these can also be detected for 2 to 4 weeks. Management. So how do we manage such patients? So a lot of the times, patients many programs can require termination of MAT as a condition of acceptance. Like, hey, you're drinking alcohol, we can no longer prescribe buprenorphine. However, there is no justifiable clinical reason to deny entry for treatment for patients on MAT. In the acute period, it is especially important that we manage our patients for alcohol withdrawal. Psychosocial interventions and brief interventions have also been found to be useful. In terms of pharmacotherapy, so we all know for the general population, we can use naltrexone, disulfiram, and acamprosate. Off-label, we can use Topamax, we can use gabapentin. In our patients who also have a co-occurring opioid use disorder, we cannot use naltrexone because of the risk of precipitated withdrawal. There have been no studies conducted for use of acamprosate among patients on MAT who misuse alcohol. Studies with disulfiram are limited. So using extended release naltrexone has shown to be effective for opioid and alcohol use disorder. What we often see in our clinic is the patients are on Suboxone and they're very hesitant to switch to naltrexone. And also remember that if we are trying to switch a patient, say you are able to convince them to use naltrexone for both disorders, they have to be detoxed for at least 10 to 14 days. Here is another image depicting how naltrexone blocks effects of alcohol in the brain. So you have your alcohol, you have your mu receptor, naltrexone sits on there and prevents, so kind of affects that reward pathway. So there's less dopamine. All right, so this comes to our conclusion of this presentation. So just to summarize, we need to do more research. The current data indicate that alcohol use disorder are a significant problem in about a third of patients in opioid maintenance therapy, and they can have a significant impact on morbidity and mortality. According to most of these studies, MAT does not change alcohol consumption, or at least not in majority of the cases, but sometimes these dose adjustments may help to reduce the risk of substance use, including alcohol. Brief interventions and treatment modifications, such as regular visits or a more intense approach, may be helpful. And we should definitely screen our patients for alcohol use, and we should advise them routinely of the compounded risk of acute and chronic alcohol consumption while on MAT, and in particular, the risk of relapse to illicit opioid use. And I also want to mention how it can both using both concurrently can also affect the pain pathway as well. So that being said, this concludes my presentation. Here are my references. Does anyone have any questions?
Thank you, Simona. That was a fabulous presentation. That was a ton of information jam-packed in there. And I love the slide with the receptors in the beginning with the mu receptor and the alcohol. That was a lovely slide. I will be pulling that one out for myself for future reference. Thank you. It looks like we do have a question from Shannon about naltrexone. Is your microphone working, Shannon, yet? Or do you need to type it in the box? Yep, don't think I have the mic set up yet. Okay. You can go ahead. Yeah, we can't hear you. Yeah, type it in the box and I'll say it out for everybody. While Shannon's typing that in the box for us, and if you don't mind, Shannon, when you type your question, just type into a little bit about yourself. Thank you. While she's doing that, Sudha, if you could unmute and introduce, please. Sudha, are you with your computer right now? Right, as soon as I see her unmute the microphone, I'll go back to her. She may have some issues too. Suzanne, if you could unmute and introduce, please.
Yeah, hi, this is Dr. Suzanne Fletcher, and I'm internal medicine, but addiction physician and working for free for my son.
Wonderful.
In
Thank you
Goodlettsville, Tennessee.
Yes, it's good to see you again, Suzanne. Thank you for joining us.
Sure.
And then I saw Ryan. Ryan has joined us. Ryan, if you could unmute and introduce, please.
Yeah, hi, I am Ryan Toole. I'm the clinical pharmacist at ETSU Family Medicine and help out as a hub team member. And I'm in John.
Thank you for joining us, Ryan. It's good to see you. And I do want to point out to you all, if you haven't been noticing them, I want to draw your attention to them now. Rick Wallace is our fabulous med librarian, and he provides us with some amazing articles related to what we've been discussing. So he had put one up a little bit earlier, and then I've noticed he's got another string of them, feasibility and safety of extended release naltrexone, opioid and alcohol use disorder in HIV clinics, pilot feasibility. So there's just a treasure trove of things that he has shared with us. So copy those down, and I think Brian may have the ability to copy those down too and put them in our resources page on our ETSU BMAT webpage. So you can look back on that page as well for to re-access it if you weren't able to save it today or you only got part of it. So do look on that resource page. Shannon is associate professor with ETSU Department of Psychiatry and also board certified in addiction medicine. There is a protocol on the APA website about switching to extended release naltrexone after microinduction onto buprenorphine. Have any of you tried this? I just lost, there it is. I'm going to find the slide and share it with you here. Excellent. It's embedded in an APA slideshow. That would be fabulous. I have heard of microdosing, doing that kind of induction onto buprenorphine. It is not something I have done myself, so I open it to the rest of the group to see if anyone else has done that, had experience with that. And Shannon hasn't done it either, but it takes about a week. Have you had that experience? Have you ever done that micro dosing induction, Cameron? No, yeah, I haven't done it either. I do think our opioid treatment facility here in town, I do think that the psychiatrist over there has possibly done it. And I know there's a provider in town who's done it. It's not Budapest. It has another name. The two fellows, do you remember the name of that that protocol? Do you remember it? I'm blanking on it. It does start with a B. It's a B word. I feel like it's the name of a place. Is that something that you guys have come across in your rotations?
Hi, Dr. Troxler. So I've seen naltrexone, induction and stuff like that, but in a patient with opioid use disorder, but it wasn't co-occurring alcohol, and I don't know if they were on buprenorphine. So, what is microinduction? Is it just like a small dose of buprenorphine, like just to kind of keep them stable before?
And actually, Shannon, I'm going to ask you this: is it? Let me look back. Is it where you are microdosing? Yeah, onto buprenorphine. So you're asking about switching to extended release naltrexone after microinduction onto bupe. Because I've seen it the other way where they're microdosing buprenorphine. There was actually, the patient I was thinking of was a patient that was on methadone and doing the switch over to buprenorphine and using microdosing of buprenorphine in that setting because we're not able to access the methadone. Actually, I think the methadone caused Torsades de Pointe. They had a prolonged QT. It was ugly. And so they were switching over to buprenorphine for that reason. That's where I've seen it.
That's called the Bernice Method. I know Dr. Seaton at Overmountain uses that.
Yes.
I think that's right.
Yes, it is. You're right. I'm like, it starts with a B. It's not Budapest. Burmese? Is that what you said?
I think so.
Okay. All right. Yeah. And it's exactly who I was thinking of. It's Dr. Seaton that I'd had that conversation with. We were needing to switch someone from methadone to buprenorphine because of a cardiac issue on the methadone. But they did not want to be on naltrexone. They still wanted an opioid agonist instead of antagonist like you would get with naltrexone.
Hey everyone, I'm Jack Larson. I'm one of the residents over at ATSU in Kingsport. I actually heard a little bit about this at the national conference over the weekend. And it seemed like most of the people that were doing the microdosing were doing it in the context of fentanyl use because that was hanging around so long in the system. They're worried about giving people full doses of bupe and that throwing them into withdrawal. So the concern was starting a lower dose of buprenorphine with the microdosing thing. And I guess they're are suggesting that helps.
Wonderful. And Jack, thank you for introducing yourself, because I was about to drop down my chat box and like, where did the person go that I needed to ask to introduce themselves? So thank you for doing that. That was awesome. And then also in the chat box, Shannon has provided us with, thank you for doing that, because that is something I'm going to want to pull down and look at as well. Adding very small doses while on the end of withdrawal, getting buprenorphine in the system faster and safer, and reviewing slide 29 gives you the protocol for faster induction onto naltrexone. So one of the things I have not done, but I've certainly read about as well, is when they cannot make that window, like you have to remain abstinent for X amount of time off of an opioid to start the naltrexone. And so you actually will kind of like, it's going to sort of super suck, but I'm going to have very small doses of naltrexone as we're coming off of the opioid, because the naltrexone is going to get in there and push more of it off. So you actually just kind of ride through sort of almost like a quicker withdrawal by having the naltrexone in place. That is something that I've heard of, but I have not been able to sell it to anybody yet. So awesome. Thank you for sharing that very much. Now, I would like to see if anybody using that other 5%, or maybe you didn't even have 5% because Simona's presentation was so engrossing, to think about a patient case. Does anybody have anything they want to follow up on from patients you've talked about to us before? Because we had a new patient in clinic today that Skylar can tell us about and give us a brief rundown if no one else has a case they want to share with us. So if not, I will let Skylar take the floor.
Thank you. Interesting that your topic was this, Simona. Patient of Dr. Hales and mine today, 28-year-old male, presented on referral from actually a staff member, was the 8-year history of being on street Suboxone, occasionally got a prescription for it, but generally on street Suboxone, who also concurrently consumes excessive amounts of alcohol. And on closer questioning, he really is not certain how much he drinks. Girlfriend indicates approximately 8 drinks a day. Later discussions with him indicated he does start drinking sometime after noon. Has associated anxiety as his trigger for that. His intent for his arrival today was to taper off buprenorphine. He wanted to stop taking his opiate and seemed to have a reasonable time frame of about 6 months, although with the combined consideration of also dealing with his apparent alcohol use disorder, that we tempered that timeline with him today with a plan to begin what he came for, which was to begin tapering his buprenorphine, which he is only taking approximately 4 milligrams a day right now, which he takes in 3 or 4 divided doses with little tiny pieces. We'll look to going to 4-2-4-2-4-2 on him for this next week, but we'll go ahead and provide him enough for 4 a day. And if he has some issues with that failing or withdrawal. But our goal for this week for him was to identify how many drinks a day he consumes. Didn't ask him to change his pattern of drinking, but to intentionally record every alcoholic beverage he consumes each day for this next week with his follow-up. And then we'll begin to work with him on that particular issue. Did you have anything else to perhaps add on that, Dr. Hale?
Well, yeah, that sums the presentation, but it was interesting that for me that he is focusing on the buprenorphine instead of the alcohol, which it appears to be a bigger problem on the picture at this point. And I pointed out to the patient that usually, when we are dealing with the combined, use of the 2 substances, sometimes when you get rid of the one, the other one increases in the consumption, and we need to be careful about that. So we need to have really a good understanding of how much he is drinking, so we can monitor that one as well.
I was concerned that he really wasn't aware at all of how much he was consuming.
Any clarifying questions for Skylar or Cameron about the patient? Do you know when he started use at all? Like when his first introduction to substances was?
He started smoking at 14, started consuming alcohol at 16, began opiates at 17 or 18. So 10 years on the opiates. And the last 8 has just been Suboxone. He does have a history of injecting Suboxone, but has not injected for the last 5 or 6 years. Was Hep C the last time checked, but of course we sent that off today.
So Hep C was negative or positive in the past?
Negative in the past.
Okay. Has he been in treatment before?
He's occasionally gone to an OBOT to obtain a prescription, but not really in treatment. It was just a different dealer.
Does he have any legal issues?
None.
And you mentioned a girlfriend with him today. Do you know anything about her use?
Sober. She and he both have decreased their tobacco intake as well. She's quit. He's working on that. And she is a big supporter of his planned road to abstinence.
Good.
And they've been together. They've known each other since 2018, but they've really only been a couple for about a year.
Now, is she in recovery or has she ever had a substance use problem?
I'm sorry, I can't answer that, Veronica.
You might have mentioned this. What did he say what alcohol he drinks?
He consumes beer. I asked him whether they were normal cans or tall boys. He said they were the regular size 12 ounce. Appeared to be confirmed by his girlfriend. She was more exact about it's 8, but he was much more nebulous.
Other questions or thoughts about this patient?
And it's interesting that he was really minimizing and saying that, for example, he can go one day and not drinking. And that was interesting to hear, that he was thinking that he has ability to go a whole day and not drinking alcohol. That means that maybe he's not really having that problem. But we were able to clear that one in that session.
And he has opioid withdrawal symptoms within 24 hours of his last dose of buprenorphine.
So his goal is to come off the buprenorphine?
He wants to come off buprenorphine, and we sort of threw the alcohol out there as another substance that he's using that didn't appear to be apparent to him. With his answer that, you know, is that, do you think that's a problem? He said yes, and that was almost an afterthought that was a problem. And I think, as Dr. Hale mentioned, I think that's going to be our more longer term challenge on this young man, and need to keep him into frequent contact with us and get him into our behavioral health program.
Perfect. So since we're just starting with this gentleman, there's probably a lot yet to know about him, including like, where might we go with treatment options and things like that? Because based on the talk we just had, the presentation from Simona, like, we can get him off the buprenorphine and transition over to naltrexone. That sounds great. Let's get it done. But I know that there's so many nuances on the road from here to there, wherever there is, which is dictated by his goals and aspirations. This will be interesting to hear more about as we go forward. Who else is encountering alcohol use disorder with opioid use disorder in their clinics? I know we've got a few providers on our call today, so I'm just curious how much you guys are seeing this. I'm looking at Chris and Jack and Suzanne, our nurse practitioner residents as well, because I know you're in clinic seeing patients. How much is this coming up?
Inpatient, I see a lot of meth.
Can you say that again, Kate? My volume is not great today.
On an inpatient basis, I see more meth.
More meth?
Mm-hmm.
Okay.
Yeah, this is Chris. I see a fair number of people drinking. Now, we start off treatment informing them that that they can't drink while they're taking buprenorphine. And I did have a lady recently who, relatively young lady, who came from another treatment facility, and she had been drinking all along. Apparently didn't test biomarkers at that facility, and she was kind of surprised when she told me she drank like 6 beers a night. And I explained to her about how that increased the risk with buprenorphine, and that we would need to get her off of that. And she was willing to do that. I just had her, keep track of the number of drinks she was having a night, sort of like you guys did with that patient of yours. Okay, how much are you really drinking? Let's find that out first. And then had her gradually decrease that, because I didn't want her to get into alcohol withdrawal. And she was actually successful over about a 6-week period of just stopping drinking completely, and seemed to be happy with it, and actually felt better, and felt like her family felt like she was doing better without the drinking. So that's my experience. I've had other patients who, one actually, who that was a part of getting to, that was a big problem for him. He was an older gentleman, and he did use meth and some benzos, and but drinking was in there too. This is his top 3 substances to abuse while on buprenorphine. And actually, I've gotten him to our protocol, which we use when we do have to insist that the patient either go to residential treatment or we can't continue treatment as an outpatient because we just don't feel it's safe. And so it's a problem for us. It really is.
Thank you, Chris, for sharing, and congratulations on getting your patient to slowly titrate down and off of alcohol. That's awesome. Very awesome. Some of during the heyday, I hope the heyday is over, of COVID, and having people inpatient and not, and reduced numbers and all that we were kind of dealing with. One of the recommendations that was coming out was trying to do ambulatory detox off of alcohol and not sending people in. So being able to get someone to reduce their alcohol intake to the point that they can avoid the withdrawal, that's fabulous. I just recently finished a Librium taper for one of our patients. We did an ambulatory detox from alcohol. It always makes me nervous when I'm sending people out in the world to take lower and lower amounts of benzos and hope that they aren't drinking on top of it. So I like your method better, but.
Yeah, thank you. I would be really interested in seeing the information that you had of those recommendations if it's available.
Sure, I can certainly, I'll get those, I'll pull them and I'll have them sent out to the group email, just get them shared with everybody.
Right. All right, thank you.
Nice guidelines that I was using for him. But yeah, I will get those sent out to you. Excellent. Any other thoughts or questions about patients that you guys are seeing with opioid use disorder plus something else?
I have one that is alcohol use disorder only that I was wondering if this group maybe has some ideas, but it's patient I'm supervising, and they're local to East Tennessee, and they recently did a detox in the emergency room. I think they were there for like 3 days, and they're thinking they'd be interested in like an inpatient 28-day program targeting alcohol use disorder. And I don't know what is the best place to send them in this region. If people have different experiences or recommendations, there is insurance. This person does have insurance. I don't know what kind. And there is a history of trauma, so some PTSD. So as a dual diagnosis, but there's the polysubstance use hasn't been for decades. Alcohol is really the primary.
This guy that was asking, is that person a veteran? Do you know?
They are not a veteran. I know. I emailed Cameron, Dr. Hyel already, and was like, do you know where to send them? They're not a veteran.
So I know you said you're not sure about insurance. Are you aware if it's private or private insurance?
I don't know if it's private insurance. I assume it, I would think, but I'm not certain.
Okay, so that's going to be like pretty much the where you're going to send them, you know, who takes, because I can give you a list of private and I can give you a list of state funded, you know, but either way, wherever you send, especially there's a lot of good ones in the Nashville region, especially if he's willing to travel. Like Cumberland Heights is probably one of the oldest ones that is top notch, especially if he has a lot of trauma. They do a lot of one-on-one trauma work with people there. Of course, they take private insurance, but they also have a grant, probably already run out since it's, you know, the middle of the year. But they also do have payment plans as well. So there's Cumberland Heights, there's the Ranch that is also in Nashville. Yeah, there's lots. I can send a list. If you can find out what insurance, I can definitely get you a list of places.
Okay, thank you so much.
Yeah.
That might also just be nice to share on our resource page as well, Veronica. That list of like private insurance, these places are available. TennCare, these are the places that are available. So we can also put that up for you guys, because that is often, it's like, okay, I've got someone, they're ready, they want to do something. And then the momentum gets lost because we are slogging it out trying to find a place for someone to go to. One of the issues that we've come across, I don't even this is a can of worms I'm about to open. One of the issues we've come across is we have patients who are stable on buprenorphine for their opioid use disorder, and they're battling a different issue, alcohol or methamphetamines, and they want to go inpatient for it, and then the facility that they're going to wants to taper them off of the medicine that actually has them stable regarding opioids, which is not really patient-centered and is problematic for many different reasons. So I don't know if that's something that you guys have encountered or heard about or come across, but it is certainly a challenge that we have been dealing with on multiple occasions, and will actually be often the deciding factor for our patients. No, never mind, I'm not going to inpatient. So that's also been a challenge for us. So it's good to know that the patient you're asking about, Meredith, we don't have to worry about tapering them off of buprenorphine. So. Any other patient encounters you guys want to share with us, or questions that you have about some that have come across your dashboard, windshield, purview recently? We're a quiet bunch today. We're all contemplative at the end of April. Is it really spring? Is it going to be summer next? What is happening? And there's 10 more weeks. All right. Yes, Skylar, we know.
And we don't let the scholar go free. So one thing that I just want to highlight here, I mean, the take-home message from the presentation and the case that we saw today is alcohol is still, you know, a problem. I know that everywhere you go, they are talking about the opioid, you know, epidemic, and but if we don't ask, we don't know. And screening the patient for all the substances that is usually, you know, used is very helpful. And in this case that Skylar just mentioned, the only thing that really clued me to ask and push it a little bit was the screening that was done ahead of time before the patient comes. And I look at it and I saw that, yeah, it seems like that we do have a problem with the alcohol as well. And pointing out that the patient is going to admit it eventually, and that was very helpful on this one. So ask and they will tell you.
Yeah, it is amazing what people will tell when you just ask, when you open up that door and they invite you in. I wanted to say thank you to everyone for joining us today. We'll be back together again in 2 weeks. I think that's May 12th. Having cases is always awesome. Having just an open discussion is nice too. But when we've got a case prepared ahead of time, we end up with more to talk about, specific to a patient and the experience and what clinical questions come out of that particular case. It was nice that today's case very conveniently, new patient tied into exactly what Simona presented on, but the patient cases that you present on do not need to be associated at all. Although it's not uncommon. We end up finding like a thread of commonality between our didactic presentation and the case that we're talking about that day. But be thinking about the patients you've seen, be thinking about clinical situations or scenarios that you've been exposed to that you may have questions about or you want to know more about, and let us know about those patients that you're seeing. It enriches all of us, and all of us want to do more, see more, be more for our patients and our community. So please do not hesitate to bring us even something that you're like, I don't know about this one. Some of the most amazing learning cases for me, when the presenter started off, when I was a participant in ECHO and not a leader of ECHO, be like, well, that just sounds really simple. I don't know why they're presenting that case. And then as we started to dive into it and pull it apart, I'm like, I learned more off of that case than the most complicated case somebody could have brought. So even if you think that you've got something that seems simple, I guarantee you it is not, and we'll have a heyday with it. So don't hesitate, bring what you got. We'll enjoy it to the most. And if nothing else, just reinforcing that you guys are doing a great job. We appreciate you out there taking care of patients, having an open mind and an open heart. With that, we will see you all in 2 weeks. Thank you. Bye.